Welcome to LG PathLab's monthly pathology webinar series. Today we have Dr. Babita Kajal with us, who will be discussing bone marrow aspirates and biopsies as case-based discussions. She is a consultant histopathologist at Joseph Brant Hospital in Burlington, Ontario in Canada. Welcome, Dr. Babita, and the presentation is over to you now.
Thank you so much, Dr. Lindsay Gupta, for inviting me to do this webinar. And my main topic today is bone marrow aspirates and biopsies, and I'm mainly focusing on morphology and how do we approach the cases. So start with the first case, 72-year-old female. She had history of neck nodes. Bone marrow was done for staging purposes. CBC was within normal limits. Peripheral blood film showed no obvious lymphocytosis, and aspirate showed mild lymphocytosis, and bone marrow biopsy showed these aggregates. As you can see in here, these are small cells. They have round condensed nuclei. We are not seeing any prominent nucleoli. We are not seeing any brisk mitosis. No apoptosis is there. We are not seeing any granulomas either. No other pertinent findings are there. And then on the right side, we can see these cells. They are diffusely and strongly membranous positive for CD20. On flow cytometry, these cells, they showed CD19 positive. They were bright CD20 positive. They had dim partial CD5 expression, and they were negative for CD10. And these cells, they were expressing bright lambda chains. So diagnosis of B-cell lymphoproliferative disorder was made. Before I discuss that case, I'm going to case number 2. This is 78-year-old male with increased fatigue and shortness of breath on exertion. On the left-hand side in the peripheral blood film, you can see these round cells. They have condensed chromatin, not any prominent nucleoli. They are showing this bluish cytoplasm. This one is nucleated RBC for the comparison, but these RBCs, they have this stack formation. So this is called rouleau formation. So that's a diagnostic clue here. On bone marrow, these cells, they were CD20 positive, diffuse membranous positivity there. And those cells, they also expressed CD138 along with the cyclin D1. Flow cytometry showed this phenotype. These cells, they were bright CD20 positive. They were also positive for CD138 and 38 and CD56. And these cells, they were kappa chain restricted and negative for CD19 and CD117. On FIT studies, these cells, they detected heavy chain locus immunoglobulin and cyclin D1 rearrangement. So what's the diagnosis in these two cases? So first of all, what is common in these two cases? These two cases showed lymphocytosis. They were of mature morphology. There were no prominent nucleoli, no aggressive features were seen. But these cases, they had almost morphology, but different immunophenotype. So how do we approach these kind of cases? For example, we have lymphocytosis in the marrow. Now, how do we clinically rule out various differentials? So approach is almost similar as we do in the lymph nodes. In lymph node, we look for the architecture, whether lymph node is effaced or not effaced. In bone marrow, we do not use that word. So we always go back and look for the clinical history. Next question is always they are reactive or clonal. Then we look for cell size and morphology, whether they are small, angulated, cleaved, they are large. Is there any monocytoid appearance? Do they have any amount of cytoplasm? And what's the location? Whether they are paratabicular and not non-paratabicular, and whether they are forming the diffuse sheets or they are forming the vague nodules or tight clusters. So then we need to look for any background necrosis, mitosis, apoptosis, any granulomas, any epithelial clusters, or any other pertinent finding. We need to look for that. So for example, we get these kind of biopsies when we get incidental findings of lymphoid aggregates in bone marrow. So bone marrow was done for some other reason, but then we start seeing these aggregates. So on the left-hand side, you can see this is a bone marrow aspirate, and we are seeing these two clusters here. So first of all, these clusters, they have different size. They have infiltrative pattern. Here you can see these are infiltrating into the fat cells. They don't have any concentric well-defined margin here. And on the right side, you can see these cells, they are small, condensed, without prominent nucleoli. There is no brisk mitosis or apoptosis going on. We are not seeing any granuloma. And based upon this, so now the differential is whether these are clonal or benign. In elderly patient, if these are benign, we should not see more than 3 or more, and they should have small size, less than 600 micrometer, but exceptions are always there. They should have round outline, but in this one, as I mentioned previously, they have infiltrated border. So these are clonal one. So this actually was a case of CLL. So that's how we can differentiate between reactive and malignant one, and we can use the IHC as well. So our previous two cases, those were, first case was mantle cell lymphoma. It was a known case of mantle cell lymphoma of the neck nodes and now involving the bone marrow. Second case had lymphoplasmacytic morphology, but actually had plasma cell phenotype, and they were also expressing cyclin D1. So when you have very limited amount of IHC to work with, and then you have to be very careful because there are few diagnostic pitfalls. CD20 is considered as one of the robust marker of B-cell lymphoma, but not all the B-cell, they express CD20, and few B-cell lymphomas are typically negative for CD20. So that's the list of CD20 negative lymphomas. For example, plasmablastic lymphoma, B-cell lymphoblastic lymphoma leukemia, HHV8 primary effusion lymphoma, and ALK positive diffuse B-cell lymphoma. And CD20 would be negative after rituximab treatment as well. And cyclin D1 also we all not only see in mantle cell lymphoma, but we can see also in B cell CLL, hairy cell leukemia, splenic lymphoma with villous lymphocytes, and very rarely, less than 1% of the cases we can see in anaplastic T cell lymphomas as well. And these are very aggressive lymphomas. Moving on to case number 3, this is 65-year-old female. She had history of anemia. CBC showed hemoglobin 83 gram per liter. There were no other CBC pertinent findings. On the left-hand side, you can see in the peripheral blood film, there is not increase in TLC. We are not seeing any immature cells. We are not seeing any blast cells. We are not seeing any left shift. We are not again seeing any nucleated RBC either. The only significant finding here, we can see again these RBCs, they are forming the stacking, and this is rouleau formation again. On the right-hand side, in the aspirate, we are seeing these very blue cells. They have this cluster formation. They have eccentric nuclei and very condensed chromatin and very blue cytoplasm. These are the normal mature lymphocytes for the comparison. And this one is one nucleated RBC for the comparison. And this is one blue histiocyte. So these cells typically are morphologically compatible with plasma cells. On flow cytometry, that's the typical phenotype. These cells, they would be CD5, 45 dim, CD38, CD138, CD56, and they would be negative for CD20. And these cells, they were positive for cytoplasmic lambda chains, and diagnosis of plasma cell neoplasm was made. Bone marrow aspirate also showed almost 65% of the plasma cells, and they were of mature morphology. There were no other significant findings seen. This is bone marrow biopsy. Here you can see diffuse sheets of these cells. These cells, they have again eccentric nuclei, condensed clumped chromatin, eosinophilic abundant cytoplasm. Again, we are not seeing any aggressive features. For example, we are not seeing any prominent nucleoli, mitosis, bizarre giant cells. And these cells, they expressed CD38, 138, which is membranous positivity. So once we have plasma cells in the bone marrow, so similar like lymphocytosis, we have to have an approach to differentiate these plasma cells in the marrow. So how do we approach these cases? So first of all, we always need to go back and look for the clinical history. Next question is always reactive or clonal. Is there any cutoff of cells less than 10% or more than 10%? Then we need to look for the morphology, whether they are mature classical plasma cells or they do have immature morphology. There are various reactive conditions where we can see reactive plasmacytosis. For example, in chronic inflammations, infections, there are various immune causes, anemias, and some malignancies where we can see reactive plasmacytosis. So in aspirates, if there is a reactive plasmacytosis, there would be aggregates of less than 10 plasma cells, but exceptions are always there. If those cells, they are clonal one, then we have plasma cell neoplasms, and then for the subgrouping, we can say these are plasma cell myeloma, plasmacytoma, osteosclerotic myeloma, immunoglobulin deposition disease, or heavy chain disease. One of the diagnostic pitfall in aspirate and biopsy is counting of the plasma cells, because these cells, they have patchy distribution, and that can lead to underestimation of plasma cells in marrow up to 30%. So always try to do multiple counts on multiple slides. And then in biopsy, always do CD138, because morphologically mature lymphocytes and plasma cells, we cannot differentiate. So always do 138 to highlight those plasma cells in the background. And flow cytometry also underestimates the plasma cells. So when we are enumerating and when we are giving the cellularity of plasma cells in the bone marrow and aspirate, do keep these points in mind. Once we know plasma cells are clonal, then do Congo red stain for amyloid. And once amyloid is positive, then do send block for typing. So that is done by mass photospectrophotometry. Sometimes we get these kind of cells. These are forming the diffuse sheets. These cells, they are very aggressive looking. They are forming cohesive like sheets. And here there are mitosis. There are few bizarre giant cells. Some of the cells, they are showing abundant cytoplasm. Some of the cells showing prominent nucleoli as well. So this case more look like carcinoma rather than hematolymphoid neoplasm. And these cells, they expressed CD138 as well. So this was a case of an immature plasma cell neoplasm. So plasma cells, they can look very aggressive. This is typical picture of amyloid. Here on the left side, you are seeing clusters of lymphocytes. These are the clusters of plasma cells. And this amorphous pinkish material is amyloid, which would stain Congo red, would give this salmon pink appearance. And under the bipolar polarization, they would have apple green color. Moving on to case number 4, this is 73-year-old female. She had increased platelets. Clinical question was to rule out primary myelofibrosis versus essential thrombocythemia. Platelets, they were 494, and on molecular testing, she was JAK2 positive. On the left-hand side, this is peripheral blood film. First of all, we can see there is increased in total leukocyte count, but we are not seeing any immature cells. We are not seeing any blast either. We are not seeing any left shift. This is one of the nucleated RBC here. Main finding here are these giant platelets. First of all, platelet count is increased, and then we are seeing these bigger platelets. On the right-hand side, this bone marrow aspirate is quite cellular. We are seeing very few fat spaces here. Everything is increased. For example, granulopoiesis, erythropoiesis, they are both increased, but main significant finding here are these megakaryocytes. They are very dysplastic looking. For example, you can see this one is very hyperchromatic. This is bizarre looking. This is hyperchromatic. This is hyperlobated one, and they are also forming the clusters. So this is a morphological clue for any myeloproliferative disorder. So in the bone marrow biopsy, then we need to do the reticulin stain to look for the fibrosis, and based upon degree of fibrosis, we grade them. So this one is at least grade 2. So once we have this kind of fibrosis, we need to do the trichrome stain to look for the collagen, because that would increase the grading of the fibrosis. And we also need to do CD34 to look for the blast. In this one, we are not seeing any blast increase. So this case actually was a known case of essential thrombocythemia, and now this patient developed fibrosis. So the diagnosis was rendered as post-ET myelofibrosis. But sometimes we do not have any previous history. We do not have any previous history of any kind of myeloproliferative disorder. And then you get that kind of hypercellular and hyper mature megakaryocytes. So we need to differentiate whether this is ET or myelofibrosis. So this is a very nice paper. So this paper is essential thrombocythemia versus early primary myelofibrosis, a multicentric study. Excellent pictures. On the left-hand side, you can see, first of all, there is not age-matched cellularity increased. Only we are seeing these megakaryocytes, which are giant, mature, hypermature, hyperlobulated. They have deeply folded nuclei, but in the background, granulocytic and erythropoiesis, they are in proportion. And if we do reticulin stain in these cases, we should not see any reticulin fibers. On the right-hand side, first of all, this is packed marrow. We are seeing granulopoiesis, decreased erythropoiesis, but again significant finding here, these hypermature, hyperlobulated and folded nuclei, and they are forming the clusters. So this is typical of myelofibrosis, and if this case is an early one, then we should not see significant increase in the reticulin fibers. So morphologically, there are clues to differentiate between essential thrombocythemia and myelofibrosis, but in real life, sometimes it's very difficult, and then you might end up saying it's an overlapping syndrome, and then we go from there. This case is primary myelofibrosis. Again, you can see this is very packed marrow. I'm seeing only one fat space here, but significantly increased megakaryocytes, and they are hyperlobated, hyperchromated. They are very dysplastic and bizarre looking, and cellularity in the background is quite increased. So this was primary myelofibrosis. Moving on to case number 5, this patient is 56-year-old female. She had fever, neutropenia, ferritin was markedly increased. Clinical diagnosis was to rule out MDS or leukemia or LHL. On the left-hand side in the peripheral blood film, this patient had bicytopenia. So there were very few cells to look at. This one is mature lymphocyte. Size is almost similar to the RBC. On the top, you can see this cell is quite big. It has high NC ratio. Nuclei is large, round, and also showing prominent nucleoli here. And this has little bit bluish cytoplasm. On the right side, you can see this is quite packed marrow. Few fat spaces are there, but there is increase in these immature looking cells. So cells, they have round outline, very open vesicular kind of chromatin. Few of the cells, they are showing prominent nucleoli as well, and there are bizarre giant cells. So these cells morphologically, they are looking like very immature kind of cells, and there is also one mitosis here. CD20 was done, which was actually negative in these bigger cells. As you can see here, these cells, they are negative here. Sorry. And these cells, again here, they have open chromatin, prominent nucleoli, and these cells, they are negative for CD20. Background CD20 is positive in few of the B cells. On flow cytometry, these cells, they had CD20 negative expression. They were positive for CD38, and they were also negative for CD34, which is a marker for blast. No light chains were detected. On IHC, these cells, they were positive for various markers, negative for CD20, but they were positive for TDT, which is a marker of immature B cells, and these cells, they were positive for lambda light chains. So based upon morphology and flow cytometry and IHC expression, diagnosis of B cell ALL was made. So B cell acute lymphoblastic leukemia in adult population is very rare as compared to AML. Rather, 80% of the childhood leukemias, they are ALL. So we need to keep that in mind. Case number 6. This is a 60-year-old male with clinical history of organomegaly. Patient had enlarged spleen, and on CBC there was bicytopenia. In peripheral blood film and in aspirate, there was lymphocytosis, and on flow cytometry again, there was lymphocytosis, and lymphocytes were approximately 78% of the total leukocyte count. This patient was also screened for the MDS, which was negative. So here in the peripheral blood film, you can see different types of lymphocytes. First of all, there was pancytopenia, bicytopenia, so very few cells are there. So this one is mature lymphocyte. You can see very condensed chromatin, size is almost similar to the RBC. And then this one is bit large, has granular cytoplasm and open vesicular kind of nuclei. In the center, this one is round, condensed lymphocyte, and this one has bluish cytoplasm. This one is looking more like a plasmacytoid or plasma cell. And on the right hand side, this is quite large cell. There is high NC ratio, and there is very feathery and fuzzy kind of cytoplasm. So this one is quite diagnostic of hairy cell. So here those different lymphocytes again. This one is more plasmacytoid. This is like granular lymphocyte. This is hairy cell, and this is a normal mature lymphocyte here. So this patient had pancytopenia, and then he had lymphocytosis, and then those lymphocytes, they were very different looking to each other. So flow cytometry showed these kind of phenotype. First population was approximately 1.1% showed CD45 DIM, CD38 positivities, CD138 positivity, and these cells they were negative for CD20, and these were cytoplasmic kappa chain restricted. So the diagnosis of plasma cell neoplasm was made in this one. Second population was approximately 4%, which showed CD103, CD11C, CD25, and CD123 expressing lambda light chains. And this phenotype is quite consistent with hairy cell leukemia. And rest of the lymphocytes, they had large granular lymphocytic phenotype. So this case was quite a challenging case because first of all, there was pancytopenia, and then lymphocytes, they have different morphology and different phenotype. So flow cytometry was very sensitive and very helpful in this case. So based upon everything altogether, this diagnosis was rendered as peripheral blood film lymphocytosis, bone marrow as hairy cell leukemia, plasma cell neoplasm, and increased LGL. Moving on to case number 7, patient is 73-year-old male with fatigue and bicytopenia. There was no previous significant history. So in the peripheral blood film, you can see these large cells. They have high ENC ratio. They have very hypergranular cytoplasm. And on the bottom, you can see this granular cytoplasm. There is OR rod present, but nuclei is quite large and is folded, and there is prominent nucleoli as well. So this cell is typical of promyelocytic kind of picture. And on the right hand side, you can see more cells. They are showing this folded reniform nuclei. This one is bit cleaved here. This one is showing prominent nucleoli. So this case was on morphology was quite consistent with acute promyelocytic leukemia, and this is a critical test result. Whenever you see these kind of cells, you need to call clinician immediately because this patient need immediate attention, and clinicians, they need to start the treatment immediately because patient have complications of DIC. They can develop DIC-like picture. This one is peripheral blood film of acute myeloid leukemia. We should usually see OR rods in acute myeloid leukemia, but in this one I didn't see any, and that was acute myeloid leukemia. So we can compare these cells with the previous slide. Here we are not seeing much granularity. We are not seeing any folded or any reniform nuclei. So that's how we can compare the acute promyelocytic and acute myeloid leukemia of non-promyelocytic phenotype. So this was acute myeloid leukemia. So take home point in the hematopathology is final diagnosis, and hematopathology is quite complex one. So we have to have everything all together to make a final comment. Going back, looking for the clinical history, any previous treatment done, any previous chemotherapy done, what are the lab values, and morphologically these cells, they are small or large, intermediate, they are forming the diffuse sheaths, nodules, and what's the flow cytometry phenotype, IHC phenotype. We need to look for the cytogenetics and molecular studies, FET studies altogether, any PCR done previously. So basically, we have to have everything all together to make the diagnosis. But there are still morphological clues, and I would say morphology still is the gold standard, despite all the molecular testing we have available. Thank you so much. Any questions, please? I'll be happy to answer those. Thank you.
Thank you so much, Dr. Babita, for the lovely presentation. And I have a question for you, please. It would be lovely if you can tell us approach a bone marrow biopsy for histopathology reporting.
Okay, so for biopsy, we have to have a kind of approach. It's a kind of synoptic checklist. So whenever we approach any biopsy, first of all, we need to look for what is the purpose of that biopsy, why it was done, what's the clinical indication, and then where is the location, like where biopsy was done, and is that adequate? What's the cellularity? Based upon cellularity, we can say is a hypocellular, or acellular. And then we need to look for the peripheral blood film, CBC findings. And then we need to look for the different lineages. So lineages mean, first of all, we look for the bigger cells, for example, megakaryocytes. So megakaryocytes, are they adequate in number? Do they have normal morphology? Are they forming any clusters? Are there any signs of dysplasia? So these are the signs we need to look for. So second, other one is we look for granulocytes. So granulocytes, again, either they are mature, immature, any signs of dysplasia again. Next question is erythropoiesis. So erythropoiesis, again, decreased, increased, dysplasia. So once we have our granulocytes and erythropoiesis all together, we can calculate our ME ratio. And based upon that, then we further proceed with looking for external or any other findings. So when I say external, then we need to look for any epithelial clusters or any metastatic deposits. So other findings mean, are there any lymphocytes? So are they forming any aggregates? What is the location? Are they paratrabecular or non-paratrabecular? If they are paratrabecular, we need to think about the follicular lymphoma. If they are non-paratrabecular, we are thinking about other lymphoma leukemias. And for example, if they are forming the aggregates, are they small size cell? Then probably you're looking for CLL. Do they have any angulated? Probably they are mantle cell lymphomas. And if they have monocyte, they could be marginal zone 1. But if they have fried egg appearance, then they could be hairy cell leukemias. And in hairy cell leukemia, they would have very interstitial kind of pattern, and which would be difficult to interpret without any IC and flow cytometry basically. And other findings we need to look for, if there any iron staining that was done in the aspirate, we can incorporate that in the report as well. And other findings, for example, any cytogenetics was done, any fish study was done, any fish was done, any other molecular or any other pertinent finding. So taking all together, we can make a comment, and based upon that, how we approach the bone marrow biopsy. So that should be the approach, and that should be the checklist. Thank you so much.
That was brilliant presentation. Thank you so much. And thanks, Nia, for your help.
Thank you so much, Dr.
Thank
Gupta,
you
for
all.
having me. Thank
Okay,
you.
bye.